Good day, dear students. This lecture is on the eyelids and it is meant for your undergraduate level. During this lecture, I am going to address the following topics. First, the anatomy of the eyelids. Second, inflammations of the eyelids. Third, masses of the eyelids. And finally, malpositions of the eyelids, including congenital eyelid defects. First of all, the anatomy. And as you can see, this is a view of the front surface of the eye, as well as the upper and lower lids, together with the periorbital area of the face. And there are going to appear red arrows pointing at the points of interest. First, the point of meeting of the two eyelids laterally, and this is called the lateral canthus, and it takes the shape of an acute angle in comparison to the point of meeting medially, called the medial canthus, and this takes the shape of an obtuse angle, or rather a rounded shape. This is followed laterally by a small fleshy mass, reddish in color, called the caruncle, followed by the plica semilunaris, which is a fold of the conjunctiva taking the shape of an incomplete moon, and is meant to pool the tears in this medial part of the conjunctival sac for the two puncti dipped in it to aid drainage. Both the caruncle and the plica semilunaris are actually phylogenetic remnants of the vestigial structure in lower mammals called the nictitating membrane. And then comes the translucent membrane full of vessels, as you can see, that is covering the whitish structure. The semi-translucent membrane is the conjunctiva, and the whitish structure is the sclera, and the sclera meets the cornea at this arrow, which is called the corneal limbus. The point of meeting of the sclera and the cornea are the limbus, and the deep structure that is taking the color of green, gray, and yellow here is the iris, and above it is the transparent window, which is the cornea, and in the center of the iris is the rounded opening, which is jet black in color here, and this is the pupil. And finally, you can see the fold in the upper eyelid called the upper eyelid crease, sometimes called the upper palpebral crease, sometimes called the oculopalpebral crease, or simply the crease. All are names for the same structure. That is the fold in the upper eyelid, and this is very important in characterizing anybody's face. The position of this fold, its shape, its meeting with the medial and lateral canthal areas characterizes the shape of the face. And here, this is a small video footage for the mobility of the eyelids, and you can see the upper eyelid moves up and down voluntarily. You can do this yourself, while the lower eyelid does not move except with the movement of the eye. So you cannot control the movement of your lower eyelid. It moves involuntarily with the mobility of your eye globe, while the upper eyelid is under the control of your will. And the mobility of both eyelids and the eye globe aid in the resurfacing of the ocular surface. Resurfacing of the ocular surface means the formation of another surface above it by the tear film. And as you will study later on in the lacrimal system, the surface formed by the tear film is composed of three layers. The one next to the cornea is called the mucin layer, then one next to it is the aqueous layer, and the third final outer layer is the meibomian oil layer. This resurfacing is an effect of three functions. The first is the normal blink reflex, our eyelids blink 15 times a minute. And second is the congruity, the complete contact between the eyelids and the ocular surface. And finally, a normal corneal epithelium devoid of any defects like ulcers or other abnormalities. Now this is a section through the globe and the eyelids, and as you can see, the upper eyelid is covered from the inside by the palpebral conjunctiva, and the eye globe is covered on the outside by the bulbar conjunctiva. Both meet at the fornix, in the upper eyelid in the upper fornix, and the lower eyelid in the lower fornix. When the eye closes, this is again the upper eyelid and the lower eyelid with the lining of the lids from inside by the palpebral conjunctiva and the covering of the sclera by the bulbar conjunctiva, and the bulbar conjunctiva inserts into the limbus. It does not cover the cornea. Now back to eye closure and opening. While the eye is open, this is the conjunctival sac. Here it is, blinking. Again, this is the conjunctival sac, blinking in light blue color, and it is an open sac. But when the eye closes, this sac becomes closed, and here it is blinking again. This closure here leads to prevention of any evaporation of the solvent, which is water. And prevention of evaporation leads to higher concentration of the solutes in this solution, and the solution becomes hypoosmolar. And this has its physiological effects on the corneal epithelium and otherwise, as you will see in your studies later on. Now the medial canthus has different shapes, and these different shapes have different names, and therefore can characterize an Asian face from a child face, from a Caucasian face, from a Negroid face, and all this. Here are the different shapes of the canthal areas, giving the different shapes of eyes and faces. This is non-racial talking, of course, but we are describing because some individuals, some patients may demand some changes in the looks of their eyes, and this is aided via surgery of the medial canthus. Now, the lid margin is the point of meeting of the lining, which is the conjunctiva, and the outer part, which is the skin. And as you can see here, the lid margin is composed of a posterior sharp margin and an anterior rounded margin. The posterior sharp margin helps in spreading the tears over the globe. And this spreading is just like the windshield of a car spreading water over the windshield. I mean the wiper or the windshield, spreading the water on the windshield. And it has to be sharp enough to effect a very effective and functioning resurfacing. This posterior lid margin is followed by the gray line, and the gray line, as we will see later on, is the mark for the splitting of the eyelids into the internal lamella, composed of the palpebral conjunctiva and the tarsus, while the outer lamella is composed of the skin and muscle. And this is followed by openings of the meibomian glands, and the meibomian glands are inside the tarsus, followed by the eyelashes that is before the anterior rounded margin. And as you can see here, this is following a picture of the surface anatomy, the anterior surface of the eye, but with the lower lid pulled out and down. Number one is the limbus, number two is the conjunctiva covering the sclera, and number three is the inferior fornix. Number five is the elevation on the lid margin called the lacrimal papilla with an opening in it called the lacrimal punctum leading to the lacrimal canaliculus. And here, number 4 is the lining of the eyelid, which is the palpebral conjunctiva, and number 6 is the lid margin. Here is a diagrammatic section in the eyelid where you can see from your left to your right the skin followed by the muscle and then followed by the gray line followed by the openings of the meibomian glands in the tarsus and finally the lining of the palpebral conjunctiva. So the eyelids is composed like a sandwich of two layers, an outer, or let's say two lamellae. The outer lamella is the skin and muscle, and the inner lamella is the tarsus and conjunctiva. And actually, the palpebral conjunctiva that is lining the tarsus is very adherent to it to the extent that it's just an epithelium with minimal corium over the tarsus. Nobody, no surgeon can separate these from one another. While the skin and muscle are one layer, if you open into the gray line, you will split the lid in this line into an outer lamella and an inner lamella. And as you can see in this section, which is a sagittal section, the eyelashes are 3 to 4 rows, and the upper eyelid are directed forwards, upwards, and laterally, while the lower lid are directed downwards, forwards, and laterally. The eyelid has muscles, and the first muscle is the orbicularis muscle, here cut perpendicular on its fibers, and the levator palpebrae superioris muscle coming from behind in a common origin with other extraocular muscles to pierce the orbital septum and become inserted in many parts. The orbital septum is the continuation of the tarsus into the orbital bony margin. And at this stage, I'd like you to know that the tarsus is not composed of cartilage, but it is a fibrous tissue of a rather tough, rubbery nature. It is a modified fibrous tissue layer that lodges the meibomian glands, which secrete the oil that forms the outermost layer of the tear film. This is an actual histological section of the eyelid, where you can see to the right side the blue indented line of the epithelium, and here's a hair follicle, and you can see the section through the orbicularis muscle with some fibers of the levator palpebrae superioris coming into the skin, and actually the insertion of the levator palpebrae superioris slips into the skin is the cause of formation of the upper lid crease. And then comes the racemose pattern of the meibomian glands within the tarsus, and finally to your right side, to your right side is the lining of the tarsus, which is the palpebral conjunctiva. Now from a front view, in a dissection, if you remove the skin and muscle, you can have a view of the meibomian glands inside the tarsus, and these are 15 to 30 in number, more in the upper eyelid. And as you can see, the semilunar structure here in the upper eyelid is the tarsus, and the lower eyelid the same, but it is rather smaller. At your level, we wouldn't mention dimensions, but enough to know that the upper one is the bigger one, and it is full of the meibomian glands, which are tubulo-racemose in nature. That means tubular and branched. And this is a diagrammatic presentation of the lid margin, where the to your left is the skin, to your right is the palpebral conjunctiva, and inside is the tarsus with the enclosed meibomian glands and the lashes, and the blue and green structures are the orbicularis and the levator successively. This is to show you again the tubulo-racemose pattern of the meibomian glands. This is an actual dissection from a cadaver where the orbit is opened from the inside of the cranial cavity. Now, please concentrate on your left side is a view from the top where you can see the nose to the front and the right orbit after taking off the cerebral hemisphere, the dura, the roof of the orbit, and the periosteum of the orbit, and you can see the muscles. The muscles here, let's see, number 4 is the muscle taking origin at the head of the orbit, at the apex of the orbit, and spreading forward like a fan to be inserted into the eyelid, unlike other muscles that are inserted into the globe. Number 5 is the globe, and number 6 here is the uh, globe covering. Number 7 is the lateral rectus. Number 8 is the superior rectus below the levator palpebrae superioris. And number 1 is the muscle that is reflected at the trochlea. So it is the superior oblique muscle. On the right side view, the nerves within the orbit. Number 4 is the muscle. And as you can see, the levator muscle, number 4, changes character from red fleshy fibers into whitish fibrous fibers, and these whitish fibrous fibers are called the aponeurosis, and the meeting between both is the Whitnell's line. Now, the eyelids take profuse blood supply from all the surrounding arteries, coming from different arteries around, mainly from the ophthalmic artery as well as the facial artery, and these can be seen under the skin, especially in children where the subcutaneous fat is not that dense. The eyelids are drained into the lymph nodes of the face, where the lateral half of the eyelids is drained into the superficial parotid lymph nodes, and the medial half is drained into the submandibular lymph nodes. Mind you, there are no lymphatics in the eye, where the lymphatic system in the eye is replaced by the aqueous system, and the orbit as well is said to have no lymphatics, although there are some evidences that there are certain parts in the orbit that have lymphatic drainage. Finally, in the anatomy of the eyelids, as you can see here, the nerve supply of the eyelids. The levator palpebrae superioris takes supply from the third cranial nerve, as well as the other extraocular muscles, except the superior oblique, which takes innervation from the fourth trochlear nerve, and the lateral rectus, which takes innervation from the sixth cranial nerve. The orbicularis muscle takes innervation from the facial nerve, and this is the sensory supply via the fifth cranial nerve via its ophthalmic branch, giving the lacrimal and the supraorbital and supratrochlear nerves, while the maxillary, which is the second division of the trigeminal fifth nerve, gives the infraorbital nerve. Finally, as an introduction to the clinical part of ophthalmology, you should acquaint yourself with what is called the slit lamp. The slit lamp is the instrument most important to the ophthalmologist for examination of the eye. And it is simply a sort of a big torch, a big light source with a microscope on it and some attached other instruments. First, this is the light source that can be controlled into a streak, into a slit, and this slit, once passes through the transparent structures of the eye, like the cornea, the aqueous, the crystalline lens, and the vitreous, can give what is called an optical section, where you can study the structure and identify disease, and is supplied with a microscope with eyepieces and objective to view these structures. And finally, there are some instruments mounted on the slit lamp, just like the applanation tonometer. By finishing your view of the anatomy of the eyelids and viewing the structure of the commonest instrument used by ophthalmologists, which is the slit lamp, we are ready now to shift to our clinical study of diseases of the eyelids. First of all, is inflammations of the eyelids, and these include the following headings you see in front of you. First of which is blepharitis, then meibomian gland dysfunction, herpes zoster ophthalmicus, stye, and chalazion. Now, this photo here shows chalazion in the lower lid. And clinically, this chalazion is a mass that appears underneath the muscle, and it originates from the tarsus. And therefore, on contraction of the orbicularis, like forcibly closing the eyes, forcibly shutting your eyes, the mass would disappear. That's because it becomes deeper as it is in the tarsus, which is deeper to the orbicularis muscle. Pathologically speaking, this mass pathogenetically originates due to metaplasia in the ducts of meibomian glands, and this metaplasia leads to obstruction. Metaplasia means change of one type of epithelium into the other, and the stratified, non-squamous, non-keratinized epithelium of the openings of the meibomian glands becomes of more layers, becomes keratinized, and in this way obstructs the openings of the meibomian glands. This leads to accumulation of the secretions of the meibomian glands inside the glands, leading to a sort of an irritation to the glands, resulting in a chronic granulomatous inflammation, which gives this mass its appearance. Once it is infected secondarily, it may become like an abscess. What's the treatment of this condition? First of all, being an inflammation, we use local steroid eye drops and ointments. And if this mass is resistant to this treatment, we may inject locally acting steroids intralesionally, that is, injection inside the mass. And if there is no response, we resort to surgery, and surgery is either excision en bloc or marsupialization. And excision en bloc is understood. Marsupialization means deroofing from the conjunctival side. It is removing a part of the deeper lamella of the tarsus, letting the glands drain into the conjunctival sac. This here is an example of a chalazion in the upper eyelid. Another example. And this is an example of multiple chalazia, where chalazia are characterized by multiplicity in the four eyelids. This condition is difficult to treat because if you do surgery and remove the chalasia, you are taking major part of the tarsus, which is the skeleton of the eyelids, and in this condition, you may lead to malpositions like entropion and ectropion. So you have to resort to medical treatment, and if not successful, you shift to intralesional injection. Now we shift to another example of inflammations of the lid margin, and this is the stye. And actually, a stye is acute suppurative inflammation in one of the hair follicles, either the hair follicle itself or any of the glands that are associated with it. Pathologically speaking, it starts by cellulitis and ends by suppuration, like any suppurative inflammation. During the stage of cellulitis, it is warm, red, and tender, and during the stage of suppuration, it forms pus and becomes white in color. Treatment of this condition depends on the stage, and during the stage of cellulitis, we start by local antibiotics and hot fomites. And don't forget that hot fomites are extremely important in improving the local blood circulation, letting all the used antibiotics as well as antibodies pour into the location, leading to antibacterial action. And during suppuration, you have to remove this pus, you have to evacuate this pus, and this usually is through epilation, that is removing the lash, or if pus doesn't come out, if it is inspissated in its position, you have to make a small incision at the top of the white area. Another example of inflammation is staphylococcal blepharitis, where there are sticky discharge flakes at the roots of the lashes. Pathologically speaking, it starts by dryness, that is dry eye syndrome, followed by infection. And as you know, the tear film is important in containing lysozymes, which are enzymes of antibacterial nature, and therefore dryness predisposes to infection. And the treatment starts again by local antibiotics, specifically fusidic acid, which is most specific antibiotic against staphylococcus. And then you do lid margin massage by massaging the lid margin, removing gently these sticky discharges, and don't forget using lubricants. Lubricants here are important in treating the predisposing dry eye. Now we shift to scaly blepharitis, which is a similar condition to staphylococcal blepharitis, but here the discharge is fluffy in nature, loosely adherent to the roots of the lashes, and is usually associated with seborrhea. By seborrhea, we mean the condition of oily skin or excessively lipid secreting skin, uh, with the appearance of dandruff in the hair of the scalp. This is associated as well with dryness, and the treatment here is loosening and removing the discharge or the scales by sodium bicarb lotion, 3% concentration, together with lid margin hygiene, as well as counseling for seborrhea. Now we shift to the next type of inflammation in the lid margin, which is meibomian gland dysfunction. This term refers to the disease process in which the secretions of the meibomian glands are neither properly secreted nor properly distributed along the lid margin. Pathologically, the process starts by either partial or complete obstruction in the openings of the meibomian glands, and this obstruction is both predisposed to and accompanied by dryness of the aqueous part of the secretion. All these conditions lead to chronic irritation in the lid margin, which results finally in dilatation of the capillaries in the lid margin called telangiectasia. This condition is treated by lid margin hygiene, which means that the lid should be mechanically rubbed and with the use of lubricants and other antibiotics and steroids. Lubricants are very important as this replaces the process of dry eye, and expression of the secretions, the inspissated secretions of the meibomian glands is very important for the ducts to open and for the secretions to flow. And finally, we may resort to mechanical probing. And by probing, we mean introducing probes into the openings of the meibomian glands, like the commercially available metallic probes, which are rather expensive. And here comes my suggestion of using the rather cheap Prolene 6O suture material to probe the lacrimal glands. I'm sorry, the meibomian glands. And then we come to herpes zoster ophthalmicus, and as you know, herpes zoster is a neurotropic virus that resides in the ganglia, in contrary to the herpes simplex virus, which is epitheliotropic. And here the zoster virus is residing in the trigeminal ganglion and therefore passes along its distribution, which involves the half of the face on the corresponding side, and here the skin is inflamed, as you can see, with a sort of rash. From inflammation to masses in the eyelids, and the masses that we have to know about are the xanthelasma, the lid cysts, the hemangioma, the pigmented lesions, and the neoplasms. Hemangiomata are either capillary or cavernous, as we shall see. Pigmented lesions are either nevus or melanoma, and neoplasms are either basal cell carcinoma or squamous cell carcinoma. Xanthelasma is deposition of cholesterol salts in the dermis layer of the skin of the eyelids, leading to what you can see in this photo as flat-topped yellowish to dirty yellowish plaques. These may be due to hypercholesterolemia, but sometimes are deposited with normal cholesterol in the blood and are treated by plastic surgical excision and repair. Lid cysts may occur in any of the glands that are already present in the lids, like the sweat glands and the sebaceous glands, and this is one clear cyst in one of the sweat glands. These are hemangiomas or hemangiomata, plural in English or in Latin. On the left side is the capillary hemangioma, which is the type that occurs in children. And this type here is causing mechanical ptosis with an S-shaped lid margin. The lid margin looks like an S on its side. And the other one is the cavernous hemangioma on the right side, which is an adult mass. A nevus is like anywhere in the body, is a pigmented mass of a benign nature. Melanoma is rather a pigmented mass of malignant nature, and basal cell carcinoma may occur on the lids or on the bridge of the nose, as you can see, and it's related to sun exposure. Details of these are beyond the limit of your study in this course. Now we shall shift to abnormal positions of the eyelids and the reminder of the anatomy. As you can see, the eyelid is composed of the following layers from the front backwards: skin, muscle, tarsus, and conjunctiva. And the lid margin is supplied with the lashes, which come in 3 to 4 rows in the upper lid, directed downwards, forwards, and laterally, and in the lower lid are directed upwards, forwards, and laterally. The abnormal positions that we are going to go through are malpositions of the lashes, which is distichiasis and trichiasis. Distichiasis is the congenital variety of abnormal lash lines. Trichiasis is maldirection of one or more of the lashes. The lid margin might be rolled inwards, which is called entropion, or outwards, which is called ectropion. The abnormal lid position as a whole might occur in ptosis or in lid retraction. And finally, we have the congenital defect called coloboma. Now, this is the normal position, the upper photo, the upper diagram, the normal direction of the upper and lower lashes. Now, here, down and to the left, the lower lid is directed, the lid margin is maldirected inwards, and this is called entropion. And the lower right diagram is ectropion, where the lid margin is directed outwards. In the normal lid, when you are looking level with the eye, you can see the lid margin that we described before, but here you cannot see the posterior lid margin. And here in ectropion, you see more, you see even the fornix of the lower lid. This is another demonstration of entropion, where the lashes are directed inwards to the extent of rubbing against the cornea. And here, this is ectropion, where the lid margin is directed outwards. These are three photographs. Up and to the left, some lashes are maldirected inwards, but not rubbing against the eye. Up and to the right, two lashes maldirected and rubbing against the cornea, and the lower photo where the upper lid is maldirected inwards. Upper lid entropion is always cicatricial, and as understandable, this cicatrization occurs in the conjunctiva. Cicatrization means fibrosis. Fibrosis is known biologically and pathologically to be contracting. It contracts with passage of time. When the inner layer of the conjunctiva contracts, it becomes shorter than the outer layer, which is the skin, and this causes simple mechanical rolling of the lid margin. The causes of this cicatrization are trachoma, which is the commonest cause, burns of the conjunctiva, Stevens-Johnson syndrome, which is the antigen-antibody reaction with deposition and subsequent cicatrization at the mucocutaneous junctions of the body as a result of exposure to drugs or some viruses and bacteria. And this cicatrization may lead to entropion. and pemphigoid, which is an autoimmune disease. Treatment is always surgical. You are not required in this course to know much about the surgical details, but I am going to touch them lightly. First is posterior lamellar repositioning. Second is transverse blepharotomy and margin rotation. Third is tarsal grafting. Here, as you can see, this is the diagram that you are very familiar with now. Skin and muscle to the front, tarsus and conjunctiva to the back. We come with a scalpel and make an incision starting at the gray line at the lid margin, separating the two lamellae, and then moving the posterior lamella to a down direction where the posterior lamella here becomes protective against the cornea from the rubbing mal-directed lashes. This is how we incise and how we suture. But the problem with this surgery is that in the beginning it is rather cosmetically bad, where a reddish lid margin may appear, but it protects the cornea against the rubbing lashes. You can see the rubbing lashes on the left and here after surgery to the right. The second technique is transverse blepharotomy with marginal rotation. We come at the crease and make a transverse incision through and through on the eyelid, and then we have an upper fixed flap and a lower rotating flap, and then take sutures so that the sutures, as you can see on the right diagram here, can roll the lower mobile flap for the lashes to be directed outwards. And this is an example of transverse blepharotomy and margin rotation, where an incision was made for these rubbing lashes, and here after the sutures were taken, the lid margin was directed outwards. Here is the view during surgery. Another example of transverse blepharotomy and margin rotation. And the last technique is tarsal grafting, where the tarsus is incised from the inside and a piece of tarsus, like a wedge, is taken from the other eye so that it does not affect its lid position, and taken into this eye and put in a groove in a wedge fashion so as to make the lashes redirect outwards. Now we come to lower lid entropion, and this condition might be congenital, might be involutional, or cicatricial. Congenital in the disease known as blepharophimosis syndrome that I'm going to describe now. Involutional means age change, means it occurs with senility. We treat the involutional type by oblique sutures, which is a temporary measure, or by transverse blepharotomy and margin rotation, just like the technique of the upper lid, or bilateral tarsal sling, and you are going to see photos later on. The cicatricial type of lower lid entropion is again treated by tarsal fracturing or grafting and transverse blepharotomy and marginal rotation. Now we come to blepharophimosis syndrome. And this syndrome is a congenital one where there is ptosis, as you can see. Both eyelids are drooped beyond the normal level, with congenital entropion as well as an epicanthus inversus. Here is ptosis, here is congenital entropion, and here is the epicanthal fold. This is a child with bilateral blepharophimosis syndrome, another child, and a third child, and this is a fourth child. The condition is treated in stages by first correcting the medial epicanthus and then correcting the ptosis, but the entropion is not treated as it resolves by itself, and as the lashes in children are so soft and they don't endanger the cornea. This is how oblique sutures are taken to repair the lower lid entropion of the involutional type. And this is the lateral tarsal sling. Here the lashes are maldirected lower lid involution entropion. We take an incision at the lateral canthus and take a small tongue from the tarsus to suture it down into the periosteum of the zygomatic arch, and in this way we can rotate the lid margin outwards. Now, from entropion, we shift to ectropion, and by ectropion is meant, as we said, rolling outwards of the lid margin. It can be paralytic, involutional, cicatricial, or mechanical. Paralytic, where paralysis occurs in the orbicularis muscle. One of the important functions of the orbicularis muscle is to make well application of the lid into the globe. Once this eyelid is not very well applied to the globe, it may roll outwards. And this is treated by tarsorrhaphy or by the lateral tarsal sling. By tarsorrhaphy, we mean suturing the two eyelids, the upper and lower eyelids together, or by the lateral tarsal sling, where in this condition, the tongue taken from the tarsus is sutured into the zygomatic arch in an upper position so as to roll the lid margin inwards. By involutional, we mean again the age-related ectropion, and this occurs due to many factors, including the laxity of the tissues, like laxity of the orbicularis, laxity of the tarsus, and so on. And we may treat it, if it is localized at the punctum, by punctal eversion or by horizontal lid shortening. Cicatrization, so as to cause ectropion, it must be in the skin, and this skin cicatrization may occur in burns in particular, and is treated by Z-plasty or by skin grafting. And finally, mechanically, masses in the lids may let it roll outwards. This is a condition where the lower punctum is everted, and we treat it by the small diamond excision of the conjunctiva, where the lid margin might be rolled inwards. This is facial paralysis, where the orbicularis muscle is so weak, not capable enough to apply the eyelid into the globe, and this is treated by horizontal shortening, but horizontal shortening is not through and through. We make two layers of the lower eyelid, which are the normal two lamellae, skin and muscle to the outside, tarsus and conjunctiva to the inside. We shorten the tarsus and conjunctiva and suture these vertically, and we excise part of the skin lateral. This helps in not making a direct vertical through and through scar, which may contract later on and increase the condition of ectropion. Here we go. We make this incision, expose the inner lamella, make a vertical incision, and then excise the extra loose skin. And this is the lateral tarsal sling, where a tongue is fashioned from the tarsus and is taken and sutured upwards in the periosteum of the arch, the zygomatic arch. Z-plasty is a complicated sort of surgery that needs knowing some geometry and having some imagination so as to shorten scars. This is scar which underwent Z-plasty where the lower lid was repositioned. This is a condition of treated lower ectropion at the punctum. And this is a severe case of burn that was treated by grafting. Finally, in malpositions, this is a congenital defect that occurs due to embryological malfunction and is treated by direct suturing to avoid exposure of the eye globe, exposure of the cornea. Now, finished with the malpositions, we come to ptosis, blepharoptosis. Ptosis means any organ in the body going down. We may talk about kidney ptosis, breast ptosis, whatever, brow ptosis. Here we are talking about blepharoptosis, where the eyelid is not in its normal position. The normal position of the eyelid is that the upper lid covers 1/6 of the cornea. If it covers more, this is called blepharoptosis. What are the causes, the etiology of blepharoptosis? The muscle that hangs the upper eyelid is the levator palpebrae superioris, and this is supplied by the third nerve and sympathetic supply as well. This muscle is fleshy in nature but attached to the tarsus through an aponeurosis. So if the nerves supplying the muscle are affected, this will lead to ptosis, and this is called neurogenic. If the muscle is affected, this is called myogenic, and if the aponeurosis is affected, this is called aponeurotic. And finally, a mass that may drop the lid causes mechanical ptosis. By neurogenic ptosis, we mean sympathetic affection, like Horner's syndrome, unilateral lesion affecting the sympathetic supply of the Horner's muscle. And the second thing is third nerve paralysis, and finally Marcus-Ganjo winking phenomenon, where the muscle going or supplying the the nerve supplying the levator is congenitally intermingled with the nerve supplying the masseter muscle of the jaw, and in this way, moving the jaw leads to ptosis. Myasthenia gravis is the disease that causes myogenic ptosis. Aponeurotic ptosis might be congenital or acquired, and the congenital is the commonest type. Now, to measure ptosis, you should go through the center of the pupil. How we evaluate a condition of blepharoptosis? Number one, you have to evaluate associations, that is, mobility of the extraocular muscles, that is, any sort of squint, and then taking history of the ptosis process. How long has it been, or any associations? Does it run in the family? Any history of trauma, any history of surgery or masses? And you have to examine the pupil, and this is because the pupil, as you know, is supplied by the parasympathetic nerves coming through the third nerve, which is carrying the motor fibers to the levator. And then we assess the degree of ptosis, which is assessed through the 2-3-4 rule. 2 millimeters or less is mild ptosis, 3 millimeter is moderate, 4 millimeters or more is severe, and this is compared to the other lid. Now, levator function estimation is also important in defining the surgery that we have to do. We have good motility, we have fair, weak, and poor. We'll see how to assess this. This is a condition of ptosis. Once the child started to chew using here his mastication muscle, you can see how the jaw winking occurred, and this is after we treated the patient. Here we examine motility in all directions in this young lady with upper lid ptosis on the left side. We examine in the all 8 directions of gaze. Now this is a condition of third nerve palsy where there is ptosis on the right side. Once we elevate the eyelid, we can notice that the medial rectus is not working, and the superior rectus as well. So this is a third nerve palsy. We should examine the pupil as well. This is how we estimate the levator function, where we should fix the eyebrow so as to stop the frontalis muscle from elevating the eyelid, and then letting the patient have a full excursion of mobility of the upper lid from the extreme lower gaze to the extreme upper gaze, and to estimate if this is good, fair, or poor mobility. This is estimation of the degree of ptosis. We examine and measure the palpebral fissure between the 2 eyelids, or compare one eye to the other, or we may take the margin to reflex distance. On the right cornea, in the lower photo here, you can see this dot of light. This is called the cornea reflex of light. We measure the distance between the margin of the eyelid to the dot of light, called margin to reflex distance. Now, the treatment of blepharoptosis is in many surgeries, but the main 3 surgery lines are are the frontalis sling, the variable resection of the levator palpebrae superioris, or tarsomulerectomy. If the levator function is poor, we do sling. If it is good, we do variable resection of the muscle. As you know from your squint study, the resection of the muscle strengthens it. And finally, if the action is good with minimal 1 millimeter ptosis, we do tarsomulerectomy. Here is the frontalis sling operation, where subcutaneous material is used to hang the lid margin into the frontalis. Different materials are used. Here how the surgery goes. This is the patient on their back with the direction of the head down. We make 6 small stab incisions, and then we pass the material within these and elevate them by making this sling. It's called the frontalis sling operation. Levator resection operation is simply a dissection procedure where we open either through the upper crease or through the conjunctiva, and then we start resecting the muscle and resuturing it into the tarsus, strengthening it with accurate measurements. Now finally we come to Fasanella serrat operation, and by Fasanella serrat we mean tarsomulerectomy. where from the inside we resect part of the tarsus with part of the involuntary muscle, which is the muscle passing from the levator into the tarsus under the sympathetic supply. And this is the Horner's muscle. Resecting it may lead to elevation of the eyelid. Here is a dissection of the skin, exposing the tarsus, taking the muscle out, resecting it. And this is fascial serrate, where the muscle and tarsus are resected from the conjunctival side. This is a poor old lady with left total ptosis, and this is a young lady of right very partial 1 millimeter ptosis, and this is left ptosis in this girl with loss and elevation of the crease. This operation here is frontalis sling. This operation here is fascial serrate, and finally this is resection of the levator muscle. Thank you very much, and in this way we're finished with the study, the lecture of eyelids for the undergraduates. Thank you very much.